بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we will continue the series of vascular imaging dealing with arterial diseases, and this is the second lecture. We have finished in the first lecture the congenital aortic lesions, and now we are going into another subject where these are the topics we would like to cover. Some of the anatomic details: arteriosclerosis, aortic calcification, porcelain aorta, Monkberg sclerosis, aortoiliac occlusive disease, or usually known as Loriche syndrome, acute aortic occlusion, aortic dissection, penetrating aortic ulcer, intramural hematoma, and finally the aortic aneurysm. And this topic will not be finished in this lecture, and it will continue in the coming lecture, inshallah. You remember that we have divided the aorta into three segments: the ascending aorta, the aortic arch, and the descending aorta. The first part of the ascending aorta is known as the aortic root, and in the arch of the aorta, it starts from the just before the origin of the innominate artery and continue to the just distal to the origin of the left subclavian artery. From this point to the point of the site of the patent ductus or the ligamentous arteriosus, this is known as the aortic isthmus. Then at the level of the diaphragm, there is a separation between the not an actual separation, but the supradiaphragmatic segment of the aorta is known as the descending thoracic aorta, and this is the abdominal aorta. The aortic root is composed of three levels: the level of the aortic annulus or the aortic valve, the level of the sinuses of Valsalva, where the coronary arteries originate, and the sinotubular junction, which is a relatively narrow constriction between the sinuses of Valsalva and the remaining part of the ascending aorta. You know that the ascending aorta normally gives three main branches: the brachiocephalic trunk or the innominate artery, which later on gives the right subclavian and right common carotid artery. Then the second branch is the left common carotid artery. The third one is the left subclavian artery. This branching pattern is the usual branching pattern, which is seen in about 70% of the cases. At sometimes the left common carotid artery and the innominate artery are originating from the arch of the aorta by a common origin, and this is seen in about 25% of the cases and is known as the bovine arch. Sometimes the left vertebral artery originates separately directly from the aorta, not from the left subclavian artery, and this is seen in about 5% of the cases. The bovine arch means that the innominate and the left common carotid artery are originating by a common trunk directly from the aorta itself, and this is seen in some of the animals. And you know that the aorta gives single branches and paired branches. The single branches are the celiac, superior mesenteric, and inferior mesenteric arteries, while the paired branches are the inferior phrenic arteries, the suprarenal and renal arteries, the gonadal arteries, and of course the lumbar arteries. Arteriosclerosis or arteriosclerotic calcification is a very common or extremely common finding in the clinical practice. And the calcium affects most of the aorta, but the most common site is the inferior border of the aortic arch, which is known as the floor of the aortic arch. Sometimes these calcifications are also associated with coronary calcification. And you should know that in arteriosclerosis, calcium is deposited in the intima, and when calcium moves inside the lumen of the aorta, this means that the intima has been displaced inside the lumen, and this is diagnostic of one of two: aortic dissection and or intramural hematoma. I will discuss the difference between both. And here you can see extensive calcification of the aortic arch as well as the descending aorta. And in the axial image, it simulates the solar eclipse sign. And this calcium may or may not associated by any other of the aortic diseases like aneurysm, for example, in this particular case, and also aortic stenosis and occlusion. Then there may be circumferential calcification or atherosclerosis calcification of the aorta, and according to the literature, calcium is present in about 18% of the cases, and severe calcification of the aorta may preclude aortic cross-clamping, and because this is a dangerous process when you are doing such in procedure. This in cases of heavy aortic calcification, this is contraindicated according to the literature. Then porcelain aorta means that there is extensive calcification of the aorta. It may reach the level of the aortic valve and extend along the walls of the aorta, as you can see in this example. And you remember, of course, the porcelain gallbladder, where you got significant calcification of the gallbladder wall. It is well known that calcium is seen in the pre-contrast images more better than in after injection of contrast, because some of the calcified plaques are masked by the density of the contrast material. Then arteriosclerosis is a generalized progressive chronic condition, and it can affect the entire vascular tree, and is a major cause of morbidity and mortality. It is responsible for about 85% of cardiovascular deaths and about 30% of deaths of other causes. Arteriosclerosis results from deposition of lipid in the intima, and this is followed by calcification of the lipid deposits. This will lead to encroachment on the arterial lumen, narrowing and even occlusion of the lumen itself. Then the arteriosclerosis will result in what we call the intimal plaque, and this intimal plaque may ulcerate, and this ulcer may penetrate the wall of the aorta, resulting in what's known as penetrating aortic ulcer, which will be discussed in this lecture, inshallah. Then the plaque may enlarge and cause critical stenosis and ischemia, may ulcerate or rupture, leading to thrombus formation, and the thrombus may cause critical ischemia, may occlude the vessel, resulting in infarction or may embolize, causing distal embolism. The plaque may undergo hemorrhage, causing a plaque expansion or rupture. And that the pressure atrophy on the underlying media may lead to the formation of an aneurysm. Then the risk factors for arteriosclerosis and also many of the arterial diseases that will be discussed in this lecture and the coming lecture as well include many factors, and the smoking is an important underlying risk factor in all of these diseases. Beside the old age, the male sex, postmenopausal females, patients with hyperlipidemia, hypertensive patients, and diabetics, the presence of family history, and the presence of homocystinuria. Then, according to the site of the plaque and the degree of encroachment on the vessel lumen, these organs will be affected. In the heart, there may be angina, myocardial infarction, cardiac failure, or arrhythmia. In the brain, there may be transient ischemic attacks, stroke, intracranial subcortical arteriosclerotic encephalopathy, which is one of the famous diseases, particularly seen in old patients and hypertensive as well as diabetics. In the kidney, you may got chronic renal impairment and hypertension. In the lower limb, you got peripheral vascular disease. In the GI, you get mesenteric ischemia or infarctions together with aneurysmal formation in any of the affected vessels, leading to the formation of aortic aneurysm. Then Monckeberg sclerosis is a degenerative disease characterized by deposition of calcium in the media of the muscular arteries. You remember that arteriosclerosis means deposition of calcium in the intima, but this deposition of calcium in the media of the vessel. It is seen also in diabetics and in patients with chronic kidney disease, and it may be seen also in young individuals without a clear underlying etiology. The underlying or the mechanism of this disease is not yet fully understood, and most of the patients are usually asymptomatic because this disease does not cause narrowing or occlusion of the vessels. But as you can see here, there is instead dilatation and tortuosity of the vessel. Sometimes patients with Monckeberg sclerosis may have calcium in the pharynx and in the larynx as well. And they also said that the breast calcification seen on mammographic images belong to this type of arterial disease, and the treatment is usually conservative. This is an example. I think that many of you have seen such an appearance, and they may got an explanation or not, but this is a classic appearance of Monckeberg medial calcific sclerosis, where you got extensive dilatation of and tortuosity of the arteries, and you got significant calcification of the arterial wall, reaching, as you can see here, the dorsalis pedis artery. We came to the other disease, which is the aortoiliac occlusive disease, or what's known Loriche syndrome. Loriche syndrome means occlusion of the aorta distal to the level of the renal arteries, and this may be associated with involvement of the common iliac or even the femoral arteries. And according to the extent of the occlusion, there are three types of Loriche syndrome. Type 1 is confined to the distal part of the aorta. Type 2 involves the common iliac arteries. Type 3 extends to the femoral and the popliteal arteries. The clinical manifestations are the triad: erectile dysfunction, thigh claudication, and absent femoral pulse. This disease may have an acute onset in particularly in females with poor outcome, reaching about 50% mortality rate. If the occlusion is of the chronic type, and the underlying causes may include arteriosclerosis, vasculitis, or thrombosis, this will result in extensive network of collateral vessels. And here, most of the arteries involved in the collateral circulation whenever the distal part of the aorta is occluded. But the most important collateral pathways include this very famous artery, which is known as the arc of Raylan, which connects the inferior mesenteric artery to the superior mesenteric artery, and this is the marginal artery of Dermont, which is a side branch of this major arc of Raylan. Also, you got some connections between the inferior mesenteric and the middle sacral artery, and between the middle sacral artery and the internal iliac veins. And all what is needed in reporting of such cases, you reported the level of obstruction and the level of the distal re-establishment of the flow, together with reporting in the collateral circulation as well. There is something which is known as the saddle embolus, and it simulates in the clinical picture and also in the radiology the Loriche syndrome. The saddle emboli represent about 10% of the peripheral emboli, and they came originally from the heart. But some other causes may include arteriosclerosis, trauma, and or dissection when it reaches the level of the aortic bifurcation. But the major cause, as you see here, 100%, about 100% of emboli come from the heart. Then 1% of patients with acute myocardial infarction have distal emboli. Then myocardial infarction is one of the underlying cause, and patients they have peripheral emboli within 3 weeks of the acute attack. Then other causes such as atrial fibrillation or other cardiac arrhythmias are reported in 70% of aortic saddle emboli. Then the mortality rate without treatment may reach about 70% of cases, while thrombectomy, either by interventions or by surgery, may improve the mortality rate to about 40%. The clinical manifestations of Loriche syndrome or aortoiliac occlusion are the 6 P's: pain, pallor, pulselessness, paralysis, paresthesia, and prostration. We came to one of the important diseases of the aorta, which is the aortic dissection. Aortic dissection means that there is separation of the intimal flap, and this will result in the division of the aortic lumen into two parts: the true lumen and the fourth lumen. Dissection occurs very commonly about 10 centimeter from the level of the aortic valve, and the second most common site is distal to the origin of the left subclavian artery. The underlying factors for dissection include continuous high pulsatile pressure and shear stress, connective tissue disorder, degenerative diseases, and weakness of the arterial wall. All what happens is some intimal tear that allows the blood to go in the subintima between the intima and the media. Then this will enlarge by time, result in the formation of a false lumen and a true lumen. According to the literature, the true lumen is usually smaller than the false lumen, but this is not seen in all cases. Then by enlargement, by time, the false lumen will compress the intima and encroach on the true lumen. The dissection or the dissecting intimal flap may progress antegrade, reaching the iliac bifurcation, or retrograde, reaching the aortic root and heart. There are two types of classifications of aortic dissection, and all depend on the involvement of the ascending aorta. The Stanford classification, which is more easy than the DeBakey type, indicates that whenever the ascending aorta is involved either alone or with other parts of the aorta, this is Stanford A. But Stanford B means that the aorta, any part of the aorta apart from the ascending aorta, is considered Stanford B. But in the Becky classification, we have three types. The Becky 1, the whole aorta. The Becky 2, the ascending only. The Becky 3A, the descending thoracic aorta. The Becky 3B, the whole descending aorta. And the Becky 3 corresponds to Stanford B. And the Becky 1 and 2 corresponds to Stanford A. I advise you to use the Stanford classification, which is more easy and well appreciated by the clinicians. Whenever you see that the intimal flap is displaced and separating the aorta into two components, then you have to differentiate between the false and the true lumen. The true lumen is usually small and is more enhanced with contrast material than the false lumen. But if you see that the intimal flap is circumferential, then the true lumen is inside the circle while the false lumen is around. And this is once more the Stanford and the Becky classification. The clinical presentation is in the form of acute severe tearing chest pain in most of the cases. This pain is anterior whenever the ascending aorta is involved and is posterior in cases of involvement of the descending aorta. Pain radiating to the neck and jaw if the branches of the aortic arch are involved by dissection. Sometimes there is no pain in 10% of the patients with connective tissue disorders. Then the clinical presentation other than pain depends on the extent of the dissecting intimal flap. The neurological manifestations may include syncope, stroke, altered mental status, hemiplegia, hemiparesis, hemianesthesia. In cases of the gastrointestinal or decompression syndromes may result from compression of the aorta of the esophagus leading to dysphagia, compression of the recurrent laryngeal nerve leading to hoarseness of voice, and the Horner syndrome if the superior sulcus or the apex of the lung is involved. And this is the summary of the clinical features of aortic dissection: pain, pulse deficit, syncope, acute onset of pain. The manifestation in the chest X-ray I will mention now. Then if you look to the chest X-ray, you will see some widening of the superior mediastinum, and you can see obliteration of the aortic knob, or you see double contour of the aorta. And if there is a atheromatous calcification, you can appreciate that this calcium is displaced inward like this case. You see here that calcium is not at the edge of the aorta, but is somewhat displaced inward. This means that the calcium is displaced following the intima, and this is the true lumen, and this is the false lumen. Here another example where you can see that calcium is present on the outer margin of the aorta. Then the intima is here. Then the diagnosis is an aortic aneurysm with mural thrombosis. But here is an intima aortic dissection with thrombosis of the false lumen. The diagnosis of both depends on where is the intimal calcification. Then, as I have mentioned, there is an intimal tear with the formation of a false lumen. The false lumen enlarges by time and compresses the true lumen. Sometimes you got in advanced cases what's known as exit tear, or sometimes it's known as re-entry tear or fenestration, and this occur distal or somewhat away from the original site of intimal tear. This exit tear may result in some complications, as I will mention now. Then here you can see the intimal flap. The true lumen is inside the intimal flap. And here also you can see the true lumen, and the outer one is the false lumen. Then in this particular case, you see that the intima containing calcium is displaced inside the aortic lumen. Then this is the true lumen, and this is the false lumen. And here the intima is displaced inside the aortic lumen. This is the true lumen, and this is the false lumen, which is thrombosed. And thrombosis of the false lumen is considered by the literature as a favorable outcome, since the aortic diameter of distal or type Stanford type B dissection increases in about 40% of cases with thrombosed false lumen, while in 90% of cases with non-thrombosed lumen. And many of the literature says that thrombosis of the false lumen is considered a sign of healing, since the false lumen is obliterated, and they said that there is no need for intervention or surgery. Then the true lumen is the smaller one. The true lumen is the more enhanced lumen. The true lumen is lined by calcium along its outer wall, while the false lumen is large and is not enhanced by contrast, similar to the true lumen, and calcium is present on its inner wall, because the inner wall is made by the intima itself. Then the reconstructed images obtained by CT are very informative in such conditions, where you can follow the false lumen in all sections, and you appreciate the false lumen and the true lumen. It is not right that the false lumen is almost always posterior and lateral to the true lumen. This is not no more right, but the false lumen is relatively large and relatively less enhanced than the true lumen. Then sometimes you got extension of the dissecting intimal flap in a branch of the aorta, like as you can see here in the left renal artery, and this will disturb the blood supply to the kidney and cause what is known as pallor of the kidney, meaning that the kidney is not well perfused. But this does not mean that the blood supply is totally occluded for the organ. When you consider that the blood supply is occluded to the organ, whenever you develop a thrombus on top of this section, and this is the dissecting aortic aneurysm that has been extended into the superior mesenteric artery, resulting in thrombosis and occlusion of the artery. The CT is very important diagnostic tool in assessment of aortic dissection, because its speed, its ability to image the whole aorta, its very high degree of accuracy, and it can assess the extension of the intimal flap through the branches of the aorta, and it can separate the dissection from an intramural hematoma, as I will mention, and most of the physicians are familiar with the CT scan. What are the findings and the CT images of aortic dissection? Number one is the presence of intimal flap. Number two is the presence of a false lumen. And as I have mentioned, the thrombosis of the false lumen indicate chronicity or healing, while if the false lumen is enhancing as much as the true lumen, you consider this as a sign of acute dissection. As mentioned before, the most common sites of dissection are 10 centimeter from the aortic valve, 1 centimeter distal to the left subclavian artery. The exit or re-entry tear may result in pleural effusion, precardial effusion, mediastinal hematoma, branch vessel involvement, or involvement of the coronary artery. And this is a case of aortic dissection where you can see that the true lumen is bigger or larger than the false lumen. As I have mentioned, this is not always the case. The false lumen is usually larger than the true lumen, but both lumens are enhanced similar to each other by contrast material, denoting that this is an acute dissection. And here you got the true lumen and the false lumen, which is less enhanced. This means that this is not acute dissection. Then in the you should remember this finding very well. In the pre-contrast scans, in cases of aortic dissection, you see nothing. This is in contradistinction to the aortic hematoma, as I will mention in this lecture. But whenever you inject contrast material, you are able to differentiate between the true lumen and the false lumen. And whenever you wait for some time, you got delayed enhancement of the true lumen. If this is a hematoma, it will not enhance, but this is the false lumen with sluggish circulation. If this is a hematoma, it will appear in the pre-contrast scan as a relatively hyperdense component, but in dissecting aortic aneurysm, you see nothing in the pre-contrast scans. Then one of the criteria of the false lumen is what is known as the peak sign. And this is what do we mean by peak sign? The false lumen has this very characteristic peak, which is helpful to discriminate the lumen, the false from the true lumen. Then whenever you diagnose aortic dissection, follow-up is indicated to assess the diameter increase of the aorta, the formation of pseudoaneurysm, the progression of the dissecting intimal flap, and the development of thrombosis within the false lumen, which may indicate healing. Also, you should notice the irregularity of the wall of the false lumen, which is a marker of increased risk of development of aortic pseudoaneurysm or aortic rupture. Then the complications of aortic dissection: number one, compression symptoms of the adjacent organs. Number two is compromise of the blood supply to the aortic branches, inducing ischemic stroke, spinal ischemia, mesenteric ischemia, and renal ischemia. Then progression of the dissection towards the ascending aorta may result in hemopericardium or cardiac tamponade, occlusion of the coronary sinus, and severe aortic regurgitation, while descending extension of the intimal flap may reach the iliac arteries, causing claudication and ischemia. Then the differential diagnosis of aortic dissection is actually the differential diagnosis of acute chest pain. And these conditions may result in acute chest pain like myocardial infarction, aortic regurg, pericardial effusion and tamponade, pneumothorax, and pulmonary embolism. Then we came to the second disease, which is included under the title of acute aortic syndromes. Acute aortic syndromes are three: aortic dissection, penetrating aortic ulcer, and intramural hematoma. Then ulcers are common, but penetrating ulcers are not common. Ulcers do not disrupt the aorta, but the penetrating ulcers may disrupt the aorta. It usually appear as a button-shaped ulcer connected to the aortic lumen by a narrow neck, as you can see here. And this thrombi of variable size may form on atheromatous plaque and may produce embolic symptoms. Then this is the classic appearance of a penetrating aortic ulcer. What happens is first there is formation of atheromatous plaque. The plaque will ulcerate, and the pressure or the blood will go through the ulcer, then disrupt the intima and goes inside the aortic wall. Then this will result in the formation of sometimes of an intramural hematoma, and may sometimes lead to aortic rupture. Then actually, according to the literature, there is no clear cutoff for penetrating aortic ulcer depth or neck that warrants treatment. But in general, a depth of more than 2 centimeter and a neck of more than 1 centimeter are reported to have higher complication rates. Then penetrating aortic ulcers are seen in older patients, in hypertensives, in smokers, which is also a great important underlying risk factor, and coronary artery disease and chronic obstructive pulmonary airway disease, or COPD. Then ulcers usually seen in the mid and distal thoracic aorta, and the ulcers are less common in the aortic arch and rare in the ascending aorta. But here you can see a penetrating ulcer in the aortic arch. And penetrating aortic ulcer may lead to dissection, may lead to saccular aneurysm, may lead to a spontaneous rupture of the aorta. The clinical presentation of penetrating aortic ulcer are almost similar to those of dissection, including acute chest pain, and sometimes the patient may have no symptoms, and penetrating ulcers can resolve completely or stay without progression. Of course, CT angiography is one of the best ways to diagnose penetrating aortic ulcer. And this is a penetrating aortic ulcer near the origin of the common of the innominate artery, and this is the surgical specimen showing, or the surgical photo showing the site of the ulcer. Then this is a separate entity, of course, which is known as ulcer-like projection. Sometimes if you image the aorta in the early phase of dissection, you got this finding, which is exactly similar to the penetrating aortic ulcer. And on the follow-up, you got the full-blown picture of dissection with intimal flap and the two lumens. This what's meant by ulcer-like projection. It is not an ulcer, but it is the start of aortic dissection. Now we came to the intramural hematoma, which is an important variant, sometimes be mistaken with the aortic dissection. Um the risk factors are if the hematoma is proximally located, if there is leakage, if there is greater anatomic extent. And you remember that the intramural hematoma will not have the same extension as dissection. It is usually limited for about 8 centimeter, but the dissection can involve the whole length of the aorta. Intramural hematoma may occur spontaneously or secondary to trauma or secondary to a penetrating aortic ulcer. And this particular entity, non-contrastivity, is important for the diagnosis. The aortic hematoma, if it is proximal, it needs surgical treatment. If it is distal in the descending aorta, it is treated conservatively. And if you look carefully here, this is the pre-contrast scan and this is the post-contrast scan. In aortic dissection, the pre-contrast scan show nothing. But here you can see a hyperdense hematoma in the wall of the aorta, whether it is the ascending or the descending aorta. And if you inject contrast material, then you can see what looks like an aortic aneurysm with mural thrombosis or a dissection of the aorta with thrombosis of the false lumen. And how can you separate these? It's by the pre-contrast scans, where you can see the appearance of the hyperdense hematoma in the wall of the aorta. This is the difference between the intramural hematoma and the dissection. Actually, the intramural hematoma is much less than the extent of the dissection. It may reach about from 8 to 12 centimeter, while the dissection extends through the aorta. Intramural hematoma do not involve the entire aorta. Then about 5 to 10% of cases will in time become frank dissections. Then the major differentiating point for the time being is just to look for the pre-contrast scans, which I think they are obtained routinely to adjust at least the dose of contrast injection in the CT angiographic studies. CT is highly accurate for identifying intramural hematoma, and the ulcer-like projection of the ascending aorta or the arch is a sign of progression to dissection. Then signs of progression and the risk include sustained or recurrent chest pain, increasing left pleural effusion, increasing maximal aortic diameter, and increasing the depth of the ulcer. And here you see the pre-contrast scan with a mural hyperdense hematoma surrounding the relatively hypodense aortic lumen. And the pre-contrast scans in cases of aortic dissection, you see nothing. But in the pre-contrast scans, in cases of intramural hematoma, you can see the relative hyperdense. This is not a very good quality image, but you can see the relatively hyperdense hematoma inside the wall of the aorta. Then, after injection of contrast, you got this appearance, which is similar to dissection. But if you wait for some time, the hematoma will not enhance. And you remember that in cases of dissection, the false lumen will later on fill with contrast material. This example you have seen before yes, you have seen before. You see the hyperdense hematoma in the ascending and descending aorta, which is clearly identified in the pre-contrast images. Sometimes they said that MRI, because of its sensitivity to different hemoglobin components of the hematoma, is able to see A subacute hemorrhage, for example, like a bright signal in the T1 and T2 weighted images, which may help you to identify the intramural hematoma. Finally, we came to the aortic aneurysm, and this is a very long subject, and we will have a small part of it in this lecture. Then we'll continue in the second lecture, inshallah. Aneurysm of the aorta is a focal dilatation of the aorta, and the diagnosis of aneurysm is considered if the aortic diameter is 1.5 times the normal diameter. For abdominal aortic aneurysms, you consider the aneurysm if the diameter of the abdominal aorta is more than 3 centimeters. Then aneurysms very commonly occur below the level of the renal arteries and proximal to the level of the common iliac arteries. According to the literature, the aortic aneurysm is the 14th leading cause of death in the United States. And the diagnosis of aneurysm depends on the measurement of the vessel diameter. And the vessel diameter depends on the site and the age of the patient. Then the upper limit for normal ascending aorta is 3.5 centimeter in the age of 20 years, and 3 and 4.5 centimeter if the patient is about 80 years old. Then, as I have mentioned before, a diameter of more than 3 centimeters of the abdominal aorta is considered an aneurysmal dilatation. Of course, aneurysm may be single or may be multiple. You got an aneurysm in the ascending and other one in the descending abdominal or thoracic aorta. The risk factors, this is one of the major risk factors for arterial diseases, and beside the age of the patient, as the aneurysms are much more common in old age and is 5 times more common in men than in women. And if the aneurysm is seen in women, it will be 10 years later than the usual age in men. Smoking is one of the major risk factors for aortic aneurysm. Also, arteriosclerosis. Smoking is also a risk factor for arteriosclerotic disease. Hypertension, positive family history, and also surgical intervention for abdominal aortic aneurysm in a first degree relative may increase the risk fourfold of developing of aortic aneurysm. The clinical presentation of the aortic aneurysm in most of the aneurysms are asymptomatic, and symptoms may result from the pressure symptoms due to the big size of the aneurysm or if the aneurysm has been ruptured. And the rupture of an abdominal aortic aneurysm is estimated to be seen in about 50%, is responsible for about 50% of 5% of sudden deaths. Aortic aneurysm can be seen on the plain X-rays by the presence of calcium in the wall. Ultrasound is a very good modality for detection of aneurysm and the thrombosed and patent lumen. CT is very important if you are intending to do an endovascular aortic repair and the stenting, of course. But the major obstacles for CT are the cost, contrast material, and the radiation exposure. CT is, the clinicians are more familiar with the CT appearances rather than the aortic appearances. Then whenever you are reporting a case of aortic aneurysm, you should consider, number one, the type of the aneurysm, the location, the size, the morphology of the neck of the aneurysm, and the signs of rupture, the presence of mural thrombosis and calcification, the state of the common iliac and the common femoral arteries. Then in either in CT or MRI, you should assess the maximal aortic diameter, the shape and the extent of the aneurysm, involvement of the aortic branches, relation to the adjacent structures, especially the bronchi and the esophagus, if the presence of mural thrombosis, detection of aortic calcification, and assessment of the coronary arteries. Then the thrombus is a hypodense, non-enhancing intraluminal lesion, which can totally surround the patent lumen and may be eccentric like this one. In all cases, you got the intimal calcification on the periphery of the aorta, not inside the aortic lumen. This means that this is an aortic aneurysm with mural thrombosis, not dissecting aortic aneurysm. Then the higher risk for a stroke is suspected in cases increase in the plaque thickness more than 4 millimeter, plaque ulceration more than 2 millimeter, the presence of mobile thrombi, and the initial detection and evaluation of the aneurysm is based on the axial images. But of course, we need the reformatted images for the measurements that I will mention immediately. There are many techniques for reformatting the images. All the technicians are well acquainted by these techniques, including the multiplanar reformation, the maximum intensity projection, the curved planar reformation, and the 3D volume rendering, and so on. Then MRI is an important diagnostic tool, but the examination time is relatively longer than that of in the CT. MRI do not use ionizing radiation. MRI is very important for evaluation of the aortic valve because of the availability of any MRI techniques. And MRI is especially useful in patients with contraindication to iodinated contrast material, because iodinated contrast material is essential for CT imaging. And also MRI is helpful in patients with known aneurysm who require multiple follow-up studies. Then the items to be fulfilled in the report. Number one, the location. The aneurysm may occur above the renal arteries. This is suprarenal. At the level of the renal arteries, this is juxtarenal, or more commonly below the level of the renal arteries, and this is infrarenal. Then the type. The aneurysm is considered saccular if it projects from one wall of the aorta, fusiform if it involves the both walls of the aorta. The size. You measure the size of the aneurysm in all the three orthogonal planes, the transverse, the anteroposterior, and the craniocaudal diameters. Then what is the neck of the aneurysm? You see the aneurysm and you go above to see the lower renal artery. The renal artery, which is more proximal to the aneurysm. And you measure the distance between the renal artery, the lower renal artery, and the aneurysm. This is the neck. And number one in the neck is the length. Number two is the diameter, the cross-sectional diameter of the neck. Number three is the configuration. Is the neck cylinder or funnel shape, for example? Then you mention the angle between the neck and the aneurysm itself, and you detect the presence of atheromas or thrombosis. Then the favorable neck for endovascular repair should not be less than 10 millimeter in length. And the neck should be a cylinder. This is favorable, while the reverse of a funnel neck is a poor, the patient is considered a poor candidate for endovascular repair. Then you mentioned the presence of calcified atheromatous plaques and non-calcified atheromatous plaques as well. Then this is the way to measure the angle of the neck in the coronal image, in the sagittal image, or in the 3D reformatted images. Also, you should assess the common iliac arteries. The common iliac arteries are assessed for the minimal diameter and maximal diameter. There are favorable and non-favorable criteria I will mention. The tortuosity, the length, the presence of atheroma, and what about the femoral axis? Is it reasonable or not? These are the unfavorable criteria for endovascular repair concerning the common iliac arteries. If the common iliac artery diameter is less than 7 millimeter or more than 22 millimeter or very tortuous or too short, less than 3 centimeter, or there is arterial stenosis or occlusion, or the presence of mural calcification more than 50% of the circumference. And you assess the transfemoral access, the femoral artery where you put your needle should be as much as you can in a healthy way with no extensive calcification, of course, no stenosis and no thrombosis. Thank you very much.